And now we're going to have a look at the serious case review of child CH. This is a 14-year-old schoolgirl, and in 2018, death by suicide, and the methodology used was hanging. She'd been sexually abused since 7 years old by multiple offenders and reported missing on over 20 occasions between July of 2017 and March of 2018. She was seen at a number of hospitals for self-harm, and she'd also overdosed on stockpiled melatonin tablets, which is a hormone, and she was also receiving mental health input. So this is a summary presentation, and you can also download the full serious case review document in relation to reading more about the actual case. So first off, what is melatonin? Well, melatonin is a prescription-only drug and it's hormones. And this is important, especially for schools and the education sector, to understand about medication. And this is why we offer the safer management and administration of medication training for education and nursery sectors, because there's a lot of issues to consider in relation to medication. Melatonin, it's a hormone that occurs naturally in people's bodies. It helps control your sleep patterns. You can take a homemade version of melatonin for short-term sleep problems, such as insomnia. It makes you fall asleep quicker and less likely to wake up during the night. It can also help with symptoms of jet lag. Melatonin is used to treat sleep problems in people aged 55 and over. It can sometimes be prescribed to help with sleep problems in children and to prevent headaches in adults. It comes as slow-release tablets and a liquid that you drink. Melatonin is available on prescription only, so it's a prescription-only medication. Melatonin is mainly used to treat sleep problems in those aged 55 or over. You'll usually take it for 1 to 4 weeks. Some people may get a headache after taking melatonin or feel tired, sick or irritable the next day. Avoid drinking alcohol or smoking whilst taking this medication. These stop the medicine working as well as it should. Melatonin is known by a brand name, Circadin. Common side effects include feeling sleepy or tired in the daytime, headaches, stomachache or feeling sick, nausea, feeling dizzy, feeling irritable or restless, dry mouth, dry or itchy skin, pains in your arms and legs, strange dreams or nighttime sweats. Serious side effects are rare and happens in less than 1 in 1,000 people. Speak to your doctor as soon as possible if you start feeling low or sad. This could be a sign of depression. Get blurry vision or your eyes become more watery than usual. You feel faint or pass out. You start feeling confused or dizzy, or things seem to be spinning around you, so vertigo. Have any bleeding that does not stop, unexplained bruising or blood in your urine, or you get psoriasis. Serious allergic reaction. In rare cases, it's possible to have a serious allergic reaction, anaphylaxis to melatonin. Now, adverse reactions. Some medicines and melatonin can interfere with each other and increase your risk of side effects. Certain medicines may increase or decrease the drowsy making, so the sedating effects of melatonin. Speak to a doctor or pharmacist before taking melatonin if you take any of the following. So antidepressants, blood pressure medicines, non-steroid anti-inflammatory medicines such as ibuprofen, estrogens, what else we got here? Antibiotics. So in schools there, you're looking particularly at your non-steroidal anti-inflammatory medicines and certainly your antibiotics. But then there's also medications in relation to epilepsy as well. Now, mixing melatonin with herbal remedies and supplements. Do not take any herbal remedies that make you feel sleepy whilst taking melatonin. They can increase the sedating effects of your medicine and make you feel much more drowsy. Other drugs, so using cannabis, heroin or methadone with melatonin will increase the medicine's sleep-inducing effects. You could go into a very deep sleep and have difficulty waking up. Talk to your doctor if you think you might use recreational drugs whilst you're taking melatonin. So getting back to the serious case review then, so if we've got a little bit of an understanding there of what that medication aspect was, the serious case review in respect of the 14-year-old child known as child CH. She died in 2018 from hanging. The inquest is yet to be held, but the coroner is aware that this report is being published. At the time of her death, child CH was in the care of Cumbria County Council and an inpatient at a mental health hospital in Lancashire. The learning identified from this review is in relation to children who are placed or in hospital outside of their home area, which require risk assessment and planning to manage self-harming behaviour, including ligaturing, practice and planning with children who are exposed to or at risk of exploitation, providing therapeutic input to a child who does not have a stable home. It was agreed that the review would consider in detail the period from November 2017 until June 2018. This was when child CH made allegations of historical sex abuse until the date of her death. There have been long-term concerns that child CH may have experienced abuse and neglect while living at home. Social workers were involved with the family for most of the child CH's life. Child CH told her social worker that she had wanted to die from a young age. She reported a history of trying to suffocate and strangle herself with objects such as pillowcases and coat hangers and writing suicide notes while she was living at home. This was not known at the time. Care proceedings commenced in May of 2016 and child CH was removed from mother's care, with significant harm being found due to long-term neglect and emotional abuse. After coming into care, child CH disclosed extensive alleged sexual abuse from multiple perpetrators from the age of 7 years old. It's possible that she had not finished her disclosures before she died. Child CH had 3 foster placements. There were concerns about whether the foster carers could keep child CH safe. There were missing episodes, the increasing risk of sexual exploitation, self-harming, and an overdose. It was at this time that CH began to disclose historic sex abuse. While CH was admitted to a children's home, placement 1, close to her family home in July 2017, the placement was chosen to maintain her school place and friendships and enable managed contact with her mother. Child Adolescent Mental Health Services, so CAMS, were involved from October 2016 until January 2017, starting when child CH was in a foster placement. The GP who made the referral stated that child CH had reported long-term suicidal thoughts, but had never had plans or intent to commit suicide. Child CH was assessed as having anxiety and low mood. She had CBT sessions with a locum therapist, which focused on risk management. With child CH agreement, she was then stepped down to CAMS Tier 2 service, My Time, for ongoing counselling. There was a long waiting list and child CH was in crisis before she was seen, and her strengthening families worker referred her back for support from Tier 3 CAMS in May 2017. Weekly therapy began along with prescription of medication to address the issues of emotional instability, impulsivity, and risky behaviours. Key episode 1, so placement 1 from July 2017. Placement 1 was privately owned children's home in Cumbria. It's a unit which is registered for up to 4 young people aged 11 to 17. At the time of her admission, child CH identified risks were self-harm, substance and alcohol misuse, and going missing. The plan was to stabilise her in placement 1 and aim for a return to a foster placement, which is what child CH wanted. It was believed that child CH needed to be in residential care for a period in order to have a break from the intensity of family life. While living in placement 1, child CH was reported missing on over 20 occasions. During her absences, there were concerns that she was being exploited criminally and sexually. Child CH would often return from the missing episode under the influence of alcohol and drugs and showing signs of sexual abuse. She provided the names of individuals who she stated she had had sex with, on one occasion admitting she had sex with an adult man to pay off a cannabis debt. Processes were followed in regards to the missing episodes. Child CH largely cooperated with the return home interviews, a commissioned service provided by Bernardo's, and developed a good relationship with the CSC Prevention Project worker who later provided one-to-one to sport work with child CH. When child CH disclosed historic sexual abuse while in placement 1, the project worker and social worker recognised the need for specialist therapeutic work and a referral was made to the NSPCC. The NSPCC allocated the case and were ready to meet with Child CH for a therapeutic intervention when the decision was made to move her out of Cumbria. It was not appropriate to start work with Child CH so close to a move, and the NSPCC believed that appropriate therapeutic interventions would be available following the move. The social worker and Barnardo's provided continuity of emotional support to Child CH at this time. Child CH had attended hospital 11 times with mental health presentations, including overdoses and deliberate ingestion of household substances, with suicidal ideation between July and December 2017. On each occasion, Child CH was seen by crisis services of Cumbria CAMS prior to discharge to ensure the discharge was safe, to put a community safety plan in place, and to ensure that follow-up care was arranged. During each mental health assessment in hospital and each arranged community CAMS appointment, she was clear that she had no plan or intent to commit suicide. The voicing of her suicidal thoughts was understood as a means of communicating her distress and to enable her to receive care and support. Placement 1 informed the local authority in February 2018 that they could no longer care for Child CH. Child CH was aware of this and accepted that moving away from the risks in the local area would be helpful. In the weeks that followed, Child CH was missing on a number of times and attended the hospital intoxicated and made allegations of sexual assault. In the meantime, funding was sought and a plan made for Child CH to spend time at a caravan with Placement 1 staff to keep her safe until funding was agreed. Key Episode 2, Placement Number 2 from March 2018. Child CH's second residential placement was a privately owned specialist unit in North Yorkshire. It provides specialist support to children and young people who have experienced or who are at risk of sexual exploitation and has on-site education. It was over 2 hours by car from Placement 1. The placement was jointly funded by the local authority and health service in Cumbria. Child CH's missing episodes and the associated ongoing risk of child sexual exploitation was the primary reason for a move of placement and for the choice of Placement 2. It was expected that Child CH would spend around 12 months there. Child CH was seen at a number of acute hospitals in Yorkshire due to self-harm incidents, and following Child CH's allegations that she had taken an overdose of stockpiled melatonin tablets, although this was believed to be untrue. She was assessed by CAMS crisis teams when she was admitted to hospital. 9 weeks into placement, Child CH tied ligatures around her neck on 2 separate occasions within one 24-hour period. Her social worker and staff from Placement 2 believed she was showing more serious suicide intent at this time. Following the second incident the next day and an assessment at another acute hospital, Child CH did not return to Placement 2. Following an internal risk assessment, the home believed that the risk of serious injury or fatality was too high to manage CH safely in the placement. They told the local authority that they could not offer the level of support and supervision that Child CH needed at this time, but that they were willing for her to return once she had received mental health support. The psychiatrist who saw her on the second admission noted that her means of self-harm had changed from cutting and ingesting substances to using ligatures, and that this was more likely to lead to a completed suicide. Child CH spent 13 days as an inpatient in the General Hospital with Placement 2 staff providing 24-hour support. The prolonged period in hospital was due to differing views and discussions about what sort of support was required, and difficulty in gaining an assessment for a Tier 4 bed for Child CH due to those differing views. While in hospital, Child CH repeated that she had planned to kill herself and that she would try again. There were various CAMS assessments stating that she would need 24-hour supervision at all times, including breaching privacy, which was not thought to be possible in a care home environment, although it was acknowledged that she required a safe and stable placement to nurture her and provide therapeutic support. Key Episode 3. Child CH was an inpatient at an NHS specialist mental health unit, also known as Tier 4 provision. In Lancashire from 29th of May 2018, the hospital provides assessment and treatment for young people between 13 and 18 years. Placement 2 was initially retained for child CH in the hope that she would return following assessment at the hospital. However, notice was given 4 days before child CH died, as Placement 2 did not believe they could provide adequate supervision with child CH's continued level of self-harm and use of ligatures while in the hospital. A request was made to the Cumbria County Council placements team for a new residential placement to be found for child CH. Child CH continued to present with ligaturing behaviours in the hospital. Staff thought that child CH used the ligatures as a way of slowing down her racing thoughts and as a way of communicating distress. On the day that child CH died, there had been no concerns about her mental state or behaviour. Child CH was found in a woodland area 4 hours after she went missing. Despite best efforts of those involved, child CH could not be resuscitated. During the period being considered, child CH lived in 2 different placements, had a 13-day stay on a paediatric ward in a general hospital, and was transferred to a Tier 4 mental health unit. The transitions led to inevitable challenges, including the need for information sharing, planning of moves, related changes of relationships when a child moves area, and potential feelings of rejection and uncertainty for child CH. Placement 1 provided child CH with residential care in her hometown. This allowed her a degree of normality because she could attend the local school, have contact with her family and friends, and remain part of her community. She also attended a local girls group, which she engaged with no matter what else was going on for her. There were issues with how her therapeutic needs could be met and with keeping her safe within the area. This was at a time when the risk to child CH from going missing and from her self-harm increased and was potentially exacerbated by the uncertainty about a proposed placement move. There were incidents of self-harm by cutting or ingesting medications or household products. She used cannabis and other often unknown substances and inhaled aerosols, which were generally accessed when she went missing. She stated at the time that misusing substances and self-harming helped her to cope with her difficult feelings and emotions. Her CAMHS worker and social worker discussed with her the impact this would have on her prescribed medication and her safety. It was acknowledged that child CH was unable to manage school and that the focus of any new placement should be on keeping child CH safe from exploitation and working with her on this issue. The Cumbria Virtual School continued to monitor child CH's situation and liaise with the social worker who maintained her personal education plan. When education was available within her placement and in hospital, child CH often engaged with what was provided. Her educational potential was compromised, however. She attended and then left 2 schools and had different education provision within placements. She had changes of GP and potentially school nursing or specialist nursing staff, had input from a number of different CAMHS workers, both community and crisis, and saw numerous hospital staff within 5 different hospitals. She had to build potential therapeutic relationships with professionals linked to her placement moves, including psychologists at placement 2 and in the mental health unit. She had to live with a number of significant losses. Shortly before she died, it was recorded at the hospital that child CH had stated she wanted a placement where she would stay forever and not have to break relations. The risks to child CH were numerous and changed over time. Initially, the risks were from her family, and the risks they posed during contact remained a concern. When she was in care, the risks for child CH were predominantly due to her self-harm and emotional and mental health difficulties, going missing, substance misuse, and sexual and criminal exploitation. At different times, the dominant risk varied. While in placement 1, the main risk to child CH was thought to be from sexual exploitation while missing and using or seeking to access cannabis and other substances, which increased her vulnerability and exacerbated her mental health issues. In placement 2, where the opportunities to go missing and access to substances was limited, the main concern was child CH's self-harming, particularly when she began to use ligatures. In all 3 key episodes, there was a pattern to child CH's behaviour with a build-up to a disclosure followed by incidents of self-harming or ligaturing. CQC guidance published in June 2017 states that ligature assessments require an understanding of the service user and group, the environment and the level of observation and supervision. They are focused on making the environment as safe as possible. Staff stated during the review that compared with other children in the mental health unit, child CH's ligaturing actions was not thought to be severe, and she never used a fixed point within the hospital. Those who knew child CH believed that her behaviours were her way of managing the distress she was in. Her self-harming and drug misuse were both described by child CH as such on a number of occasions. Those involved did have some concerns prior to her move to an isolated rural placement, included how she would manage her feelings with limited access to drugs or cigarettes prior to building therapeutic relations. While in placement 2, child CH continued to self-harm. This was thought to be a way of communicating her distress and due to an inability to regulate her emotions. When she was assessed following 2 ligature incidents in 24 hours, the psychiatrist stated that she would need 24/7 supervision, but not a Tier 4 bed. There were high expectations from non-health staff about CAMHS and/or other mental health staff being key in reducing the risk of self-harm or suicide to child CH. It was anxiety-provoking for them when there was little or limited CAMHS involvement. While child CH was in placement 1, the social worker expressed her concerns to her managers about the lack of mental health support for child CH and reported that this issue be escalated with CAMHS. She recorded that the stress is building and building for child CH and we are trying our best to support her without the help of professional mental health workers. There appears to be a particular gap in services for children like child CH, with attachment or post-traumatic stress disorders, with these children often falling between social care and health provision. NICE guidance, so the National Institute of Health and Care Excellence, guidance on attachment in children and young people recommends that services should ensure that the stability or instability of the child or young person's placement does not determine whether psychological interventions or other services are offered. On occasion, it felt hopeless and a catch-22 situation for those involved. Future in mind, the report of the government's Children and Young People's Mental Health and Wellbeing Task Force 2015 states that the provision of mental health support should not be based solely on clinical diagnosis, but on the presenting needs of the child or young person and the level of professional or family concern. The most vulnerable children who have had the most adverse childhood experiences will have varying degrees of emotional disturbance, which may or may not be identified through a specific mental health diagnosis. Future in mind is clear that services need to be integrated to ensure that responsibility is not with any single agency, be they, say, CSC, health, education, or youth justice. There were capacity issues within Cumbria CAMHS, and they told the review that they struggled to provide the required intensity and continuity of support for complex cases like child CHs at the time. There was also a reliance on agency staff. The therapist child CH engaged with was temporary and they left without notice, and this heightened child CH's issues of abandonment. Capacity and demand is likely to be an issue for all CAMHS services, as a recent NHS report states that the number of children who require support to address their mental health has increased from 9.7% in 1999 to 11.2% in 2017. The Office for National Statistics reporting in September 2018, the growing numbers of teenagers in England and Wales are killing themselves. 56 girls and women aged between 15 and 19 years killed themselves in 2017. This was the highest number on record since the records began in 1981. The suicide rate amongst that age group, 15 to 19 females, being 3.5 per 100,000. Child CH's room was not searched until after her death, when a note with some suicide ideation was found, which could have changed the risk grading if it had been found when she first went missing. Despite the learning about managing risk in the case, there are numerous examples of individual professionals spending time with child CH and providing her with care, support and advice. For example, Cumbria Police tried to ensure that child CH saw the same officers regarding her allegations. Strategies were put in place to help child CH manage contact with her mother, and a social worker ensured that child CH's bedroom was set up to allow her to self-soothe and help her manage her nightmares. Learning point. Different agencies and professionals have different thresholds regarding the perceived risk from self-harm, including using ligatures. This needs to be acknowledged. Risk assessments and plans need to be holistic, shared across disciplines, agencies and areas, and reviewed regularly. Those responsible for children who are exposed to or are at risk of exploitation must ensure that in all cases, assessments and safety plans are multi-agency, outcome-focused and appropriately shared when a child moves, including consulting with the new area of the appropriateness of a placement. Practice is trauma-informed, and processes across and within agencies should be streamlined to avoid repetition and increase bureaucracy. Education was important to Child CH, but she struggled to maintain school while in placement 1. Although she had stayed within her hometown, particularly in order to have consistency of education, Child CH left her school shortly after coming into care. A place was quickly found in another local school and a support plan was put in place. However, her attendance and engagement declined due to the emotional impact of the historic disclosures she was making. It was agreed that her emotional recovery needed to be prioritised over her education. The CSC agency report has reflected that communication between the school and placement 1 could have been improved, as the school did not always know about recent events in Child CH's life. Child CH had skills and talents, however, that were encouraged in her placements and were said to be an escape for her when she was distressed. Child CH received education on site in placement 2, and while there was no clear education plan, she also received on-site education in the mental health hospital. Child CH had a distressing and abusive childhood with no secure attachment figure. This impacted significantly on her emotional well-being. She was in a position where she desperately required therapeutic input to enable her to obtain a secure, settled placement. But this input could not happen due to the lack of such placement. Lessons have been identified about the way that agencies work together in Child CH's care. Also identified are weaknesses in the system in regards to children who are placed outside of their home area, children who self-harm and engaged in risky actions and could result in their death, and children who are hard to place due to the challenge of managing risks alongside providing a secure therapeutic home. Good practice identified. Child CH's school in Cumbria advocated a strengths-based approach, including music and other subjects she liked and was good at. 2 previous case reviews were undertaken in Cumbria where older children had taken their own lives. These were Child F in 2010 and Child J in 2013. The relevant findings from these reviews were about CAMHS in parts of Cumbria not being fit for purpose, and a view from partner agencies that a referral to CAMHS did not guarantee a safer outcome for a young person at risk of suicide. At the time, CAMHS reported long-standing and deep-seated difficulties and referred to low levels of morale, high staff turnover, sickness absence, inadequate practice in relation to risk recognition and response, poor information sharing, and a lack of leadership and direction. While the situation has improved, the use of agency staff and ongoing recruitment and retention challenges remain an issue and had an impact on Child CH. In 2018, NHS in Cumbria area undertook a review regarding a child known as X. The case had some similarities to Child CH. Recommendation 7, how can professionals be supported to ask themselves if they have the confidence to respectfully challenge other professionals if they believe that a child's needs are not being met by existing multi-agency plans? As of July of 2020, the Coroner's Court is yet to be held to establish the cause of death, and if any Regulation 28 prevention of future death reports is to be served on any of the agencies involved. The Office for National Statistics reported in September 2018 that growing numbers of teenagers in England and Wales die by suicide. Suicide rates amongst that group are 3.5. So that then brings us back to the issue about the increase in training needs analysis for suicide prevention awareness in the education sector. Now, this is something we've been delivering now in the secure sector, certainly since the mid-90s. It's something now that the education sector needs to think about, and in our DSL child protection training and our working together child protection training, we look at some of the serious case reviews over the last couple of years which have involved children from school settings who have taken their life by suicide. If you have any questions in relation to any of these issues, please contact us at Total Train. If any of this topic has distressed you, please speak to somebody who you feel you're able to talk to. Thank you.